Hello, my name's Will Blakeney. I'm an orthopaedic surgeon working at Royal Perth Hospital and UWA, and I'd like to present to you this introduction to the hip. We'll start with a brief look at the anatomy, then talk about taking a history for hip pathology, then an introduction to hip examination. We'll talk about some of the common conditions that you'll come across, and finally management of some of these conditions. I'm going to start by showing you 3 quick case vignettes. This first one is a 78-year-old gentleman who presents with a deep ache in the groin. The pain is often at night and isn't affecting his sleep. He's now having difficulty walking. Started using a stick. He has a limp. Also difficulty getting up, bending down. No history of an acute injury. The second case is an 85-year-old female. She's tripped on the carpet and has had to call an ambulance as she's in extreme pain and unable to get up. Looking at her leg on the affected side is shortened and externally rotated. The third case is that of a 45-year-old woman who has a 3-month history of lateral hip pain. She says it's worse with prolonged standing and with running. She's normally a keen runner, jogging up to 4 kilometres, but has had to stop for the past month because of the pain. She has no history of an acute injury, and when you examine her, she's tended to palpate over the greater trochanter. You can have a think about these 3 cases as we go through the rest of the presentation, and we'll revisit them at the end to put together what you've learnt. I'll give you a brief rundown of the anatomy because it is crucial for the understanding of hip pathology. Starting with the bony anatomy, I have the pelvis and the hip joint, which consists of the acetabulum and the femoral head. The femoral head, of course, is connected to the femur. Next is the capsule labrum and ligaments. The labrum is a rim of cartilage that goes around the acetabulum to provide stability for the hip and to help it contain the femoral head. Further stability is provided by the ligaments pictured here, including iliofemoral, pubofemoral and ischiofemoral. Next we'll look at muscles that move the hip, divided into groupings by function. First, the abductors of the hip, most important being the gluteus medius and minimus, which are both supplied by the superior gluteal nerve. The gluteus maximus is supplied by the inferior gluteal nerve. Next we have the adductor muscles, which are in the medial compartment of the thigh. They are mainly supplied by the obturator nerve. The adductor magnus has a dual innervation as it is part adductor, but also is in the posterior compartment of the thigh and receives sciatic nerve innervation as well. Pectineus muscle also receives femoral nerve innervation. In the anterior compartment we have the rectus femoris, which is a hip flexor innervated by the femoral nerve. The iliopsoas is also a hip flexor which has innervation from femoral nerve, as well as the lumbar nerve L2-3. In the posterior compartment, we have the hamstring muscles, biceps femoris, semimembranosus, and semitendinosus, which have sciatic nerve innervation. The gluteus maximus also functions as a hip extensor. Finally, we have the short external rotators, which are named here. This diagram also shows the close proximity to the nerves in the posterior compartment, which can be pain generators, can also be injured iatrogenically when we do a posterior approach to the hip and take off the short external rotators. The blood supply to the femoral head is extremely important in orthopaedic surgery. You can see the two main vessels, the medial femoral circumflex artery and the lateral femoral circumflex artery, form an extracapsular arterial ring, and the supply to the femoral head comes up through the retinacular arteries. This becomes important when we have a fracture to the proximal femur to determine whether or not the arterial supply is going to be compromised. We'll also see that there is the obturator artery that provides a branch, the foveal artery, into the head. This artery stops being patent by adulthood and becomes the ligamentum teres. Now we'll move to taking history for a patient with hip pathology. We want to take a focused history, asking about onset and progression of symptoms, then a pain history, which you can use the Socrates technique, then specific questions about stiffness, crepitus and locking in the hip joint, and some functional questions about walking distance, whether they are using walking aids, and any effects on their activities of daily living and vocation. Socrates is a good way to remember a structured approach to pain assessment of the hip, asking about site, onset, character, radiation, associations, time course, exacerbating/relieving factors, and severity. When we talk about hip pain, it's actually quite a broad category. We need to really zero down on the site, whether it is anterior or true groin pain, lateral or posterior or buttock pain. This diagram is a good illustration of the site of pain for different pathologies around the hip joint. Next, we will look at examination of the hip. In orthopaedics, we try to simplify examinations to look, feel, move, and special tests. Look is just observation of the patient and their hip, looking at any muscle atrophy, limb asymmetry, any scars or swelling. Also important to look at the spinal alignment, whether they have normal lumbar lordosis or if they have a scoliosis. Do they have a true and functional leg length discrepancy? And we should always assess their gait. The feel part of the examination is palpation. It is difficult to palpate the actual hip joint as it is deep in the groin, which means that the bony margins or the joint line cannot be palpated. The feel part is often considering other pathology outside the hip joint, which is part of the differential diagnosis. For example, Tenderness on palpation of the greater trochanter can easily be detected and points towards underlying diagnosis of trochanteric bursitis and or gluteal tendinopathy. Move part of the examination assesses both active and passive range of motion. The examiner should take the patient through flexion, extension, abduction, adduction, external rotation, internal rotation. These numbers represent the normal range. The examiner should always make the patient walk to assess their gait. These are some of the common gait patterns that are seen with hip pathology. The antalgic gait, the fundamental feature is that the patient spends less time on the painful limb, so that stance phase is reduced when the painful side is in contact with the floor. Basically, the patient wants to get off the painful leg as quickly as possible. In the stiff leg gait, movement of the hip joint in the sagittal plane, so flexion and extension, contributes to the swing phase of the gait cycle. If this movement is lost or markedly restricted, the patient tends to circumduct and swing their leg. And this is achieved by recruitment of more spinal movement. The short leg gait, patient as they bear weight on the shorter leg dips down. When observing the patient, it's most obvious looking at the head, which moves up and down depending on whether the shorter or long leg is in the stance phase of the gait cycle. Trendelenburg gait is a dynamic representation of the Trendelenburg test. Put simply, with each step forward that the patient takes with the affected limb, they will lurch towards the unaffected limb. It's commonly described as a rolling over on their hip as they walk. To understand the biomechanical basis of the Trendelenburg gait, we'll have a look at the Trendelenburg test in greater detail. This is the Trendelenburg test. Normally the examiner will place a finger on each anterior superior iliac spine and ask the patient to stand on one leg. Normal single-legged stance, the centre of gravity has to shift so that it lies over the weight-bearing leg. In order to do this efficiently, the pelvis is effectively pulled up on the unsupported side. The examiner will notice the finger rising on the unsupported leg, which is a normal response. If the pelvis drops on the unsupported side, to avoid falling, the person will have to throw their body towards the loaded side so that the centre of gravity is again over that foot. In this instance, the finger on the ASIS of the unsupported leg will fall, which is a positive Trendelenburg. A positive Trendelenburg sign generally means there is a problem with the abductor muscles. This can be a problem with the motor, such as a superior gluteal nerve palsy. It can be a problem with the lever arm, such as a shortening of the femoral neck or a rupture of the abductor tendon, or it could simply be a problem with the fulcrum, such as pain arising from an intra-articular pathology. Another special test is the Thomas test, named after Hugh Owen Thomas, a British orthopaedic surgeon. The test is used to rule out a hip flexion contracture. The test consists of 3 steps. First, the patient lies supine on the examination table. The examiner places their hand beneath the patient's spine to identify lumbar lordosis. Then the examiner gets the patient to flex the unaffected hip maximally, which will obliterate the lumbar lordosis, and the pelvis should be in a neutral position. The examiner in step 3 then passively arrange the affected hip into extension. If there is a fixed flexion deformity, they will not be able to get the hip into full extension without the pelvis beginning to tilt anteriorly. At the point where the pelvis begins to tilt, the degrees of extension of the hip are measured, and this is the fixed flexion deformity as demonstrated in this illustration. Another special test is FADIR, which stands for flexion, adduction and internal rotation. With the hip at 90 degrees, this is passively performed by the examiner. This will reproduce anterior groin pain for a positive response. It is a good test for labral pathology as it causes impingement of the anterolateral part of the femoral neck against the superior and anterior acetabular rim, which is a common site of labral tears. There are some other special tests for hip examinations, but in the interest of time, we'll move on. Once we have performed a history and examination, we should come up with a differential diagnosis. A simple way to think about hip pain is whether it is from intra-articular hip pathology, such as osteoarthritis, whether it is from extra-articular hip pathology, such as abductor tendonitis, or whether it is from pathology which is remote to the hip joint, such as lumbar spine facet joint arthritis, causing neural impingement. Another way to think about pain around the hip girdle but outside the hip joint is whether it is within the musculoskeletal system or outside the musculoskeletal system. Within the musculoskeletal system, we need to think about trochanteric bursitis, which is often associated with gluteus medius or minimus tendon problems. We should consider stress fractures of the proximal femur, osteitis pubis, iliopsoas tendonitis or bursitis, an iliopsoas abscess, adductor tendon strains or inflammation. Pain can be referred from the spine, or it can be a metastatic disease in the pelvis or in the femur. Do not forget pain originating outside the musculoskeletal system, such as from inguinal hernias or lymphadenopathy. Gastrointestinal, genitourinary and gynecological causes also should be considered. Neurological causes of hip pain depend on which nerve or nerve root is being affected. The schematic demonstrates where the patient will tend to localise nerve root pain from L3 through to S1. Neural impingement can also occur at the level of the peripheral nerve, be that the lateral femoral cutaneous nerve in neuralgia parasitica, or the femoral nerve, sciatic nerve, or obturator nerve. Hip pain is often broken up into anterior, lateral, or posterior pain. Anterior pain or true groin pain can be a result of these intra-articular or extra-articular causes. The most common would be osteoarthritis, but any intra-articular pathology will cause groin pain. Lateral hip pain. We most commonly see pain to palpation over the greater trochanter associated with trochanteric bursitis and gluteal tendinopathy or dysfunction. Iliotibial band syndrome and neuralgia parasitica also cause pain laterally. Posterior hip pain or buttock pain most commonly is referred pain from lumbar spine pathology with neural impingement. Piriformis syndrome is another possibility. Sacroiliac joint dysfunction will cause pain more centrally. In the picture you see a patient that's had a proximal hamstring tendon avulsion, which presents with marked bruising and hematoma. The patient may just have a hamstring strain, which will just present with pain over the buttock and down the posterior thigh. So if we look back now at our case vignettes, we should be able to come up with a differential diagnosis for this gentleman. The most common cause for his pain is going to be osteoarthritis. Nowadays, when we talk about the causes for osteoarthritis, we can separate them into mechanical and non-mechanical causes. Some of the mechanical causes that lead to osteoarthritis over time: developmental dysplasia of the hip, which is under coverage of the femoral head by the acetabulum. Conversely, over coverage, which we see with femoroacetabular impingement, can also lead to osteoarthritis. Other juvenile hip conditions such as Perthes disease or a slipped capital femoral epiphysis lead to loss of sphericity of the femoral head, which with time will lead to osteoarthritis. Post-traumatic, such as femoral head fractures with loss of congruency, similarly will result in post-traumatic osteoarthritis. The non-mechanical causes are avascular necrosis or osteonecrosis of the femoral head, inflammatory conditions such as rheumatoid arthritis, ankylosing spondylitis, and then primary disorders of the cartilage and the synovium, such as synovial chondromatosis. The most important investigation for osteoarthritis is the X-ray. This is the radiograph of the gentleman in case 1, and you can see the 4 cardinal radiographic features of osteoarthritis: the loss of joint space, which is due to hyaline cartilage loss, osteophyte formation at the acetabular rim and over the femoral head, subchondral sclerosis, which is the whitening that you see at the joint margins, and in this case there's a large acetabular subchondral cyst, the superolateral acetabulum, which is termed a geode. When we talk about management of osteoarthritis, we first need to consider non-operative treatment, rest, activity modification, weight loss, walking aids, physiotherapy and simple analgesics. But ultimately, most patients with advanced osteoarthritis are going to end up with a hip replacement. We'll move to case 2. 85-year-old female that had a fall. First thing you should be thinking about is, of course, a fractured neck of femur. In the illustration here, you see the typical shortened externally rotated limb, which we see with a fractured neck of femur. Fractured neck of femur actually has a bimodal distribution. It's most commonly low energy trauma that we see in older patients following a fall, but we can also see it in younger patients following high energy trauma, such as motor vehicle accidents or falls from height. Risk factors for fractured neck of femur are advanced age, female sex, Caucasian race, small stature, low bone mineral density or osteoporosis, and of course pre-existing medical problems such as impaired vision, poor balance or neurological conditions which increase a patient's chance of falling, malnutrition and malignancy, affect bone quality and heighten risk of fracture. The management of a fracture depends on the location of the fracture. Is it a femoral neck fracture, a trochanteric fracture, or a subtrochanteric fracture? And the importance of this goes back to our blood supply to the femoral head. If the fracture is intracapsular, then those retinacular arteries have been disrupted, and there is a high chance that the blood supply to the femoral head is compromised. If the fracture is extracapsular, such as a trochanteric fracture, then those retinacular arteries should be intact, and the blood supply to the femoral head, therefore patent. In this case, you can see the X-ray demonstrates that the fracture is intracapsular. The X-ray here demonstrates our management, which is a hemiarthroplasty. We have replaced the femoral head with a prosthesis as its blood supply is compromised. The femoral head is likely to go on to avascular necrosis if we try to fix it. When we talk about management, the operative procedure is not the only thing to consider. These patients are often frail, elderly patients with multiple medical problems, and the fractured hip is often symbolic of this frailty. Initial management for these patients is medical stabilization, rehydration, analgesia, which is best provided by a nerve block to avoid the adverse effect of strong analgesics in an elderly population. We should not forget DVT prophylaxis and skin protection to avoid pressure sores. This is best provided with a multidisciplinary approach using Orthopaedics team in combination with anaesthetics and the surgical team. There is strong evidence that these patients have improved outcomes if they are operated on within less than 24 hours. It's therefore imperative that these patients have a timely medical workup and optimization for surgery to achieve this. Here you see a radiograph of an extracapsular fracture. This is a peritrochanteric fracture involving the greater and lesser trochanters. The femoral neck is preserved, and so the blood supply should be patent. In this case, we look to fix the fracture rather than replace it. And the x-ray on the right demonstrates some of the options for fixing these femoral heads with either an extramedullary plate and screws or an intramedullary device with a nail. Finally, if we move back to case 3, 45-year-old woman with tenderness over a greater trochanter. This was gluteal tendinopathy, which is a very common pathology, the most prevalent of lower limb tendinopathies. It incorporates greater trochanteric bursitis and also is associated with iliotibial band syndrome. In the diagram you can see the trochanteric bursa as well as the gluteus medius bursa, which are commonly involved. These are intimately related to the gluteus medius and minimus tendons, which often have concomitant pathology, either tendinitis or tears. Clinical presentation is usually lateral hip pain of gradual onset. It's often associated with changes in workload or physical activity, particularly running or walking long distances. Pain will then progress to night pain, affecting patient's ability to sleep on the affected side. Single leg loading tasks, such as walking, running, standing on the leg, climbing hills or stairs, are particularly painful. Patients also note stiffness, extending the hip when getting out of a chair. MRI is the gold standard investigation. This illustration demonstrates the normal anatomy that you will see on MRI. If you look at the MRI image on the right, you see there's a 2 centimetre area of high signal intensity superior to the greater trochanter, which is labelled D. And this is where the gluteus medius tendon has pulled off with the trochanter. Gluteus medius is B. Gluteus minimus is A in the picture. Initial management: hip abductor and flexor strengthening under guidance of a physiotherapist. The aim is to decrease peak hip adduction in running, increasing cadence. Other conservative treatments include corticosteroid injection into the trochanteric bursa, although this can cause further tendon degeneration. And finally, surgical repair should be considered for tears of the gluteal tendons that aren't responding to conservative measures. That concludes our presentation on common hip conditions. I hope you enjoyed it, and please feel free to contact me with any questions or queries.